Hello, everyone. Welcome to our Africa Echo session for today. We're really excited. This is a very exciting topic, and I'm grateful to the Echo team for allowing me to be part of this today. So our topic for today's session is capacity building in cancer health service delivery at the primary care level in Africa, a health workforce advocacy and policy perspective. We have a number of panelists here joining us who will be highlighting, showcasing their amazing work in their own settings. My name is Hawa Kamara. And just before starting, I wanted to quickly highlight a few reminders for today's session. Please remember to mute your microphone if you're not speaking. That will allow us to ensure there are no interruptions and disruptions to our presentations. And also, if your bandwidth permits, we would love to see your faces. There's a great group of us from all over the world, and it would be wonderful to see you. So please turn on your video if you can. And at any time, use the chat function at the bottom of the screen to either introduce yourself, ask questions, or make any comments. There's also a function to enable subtitles at the bottom of your screen as well, if you believe that would be helpful. And also just reminding you that the session will be recorded, and in the agenda that it has been shared, we'll sending you the link where the recording will be available at a later time, usually within 1 to 2 weeks. Okay, so we'll be starting today. I see that Dr. Nyangasi was able to join us. This is wonderful. So our session will start with a didactic presentation initially by Dr. Nyangasi, and then we'll follow with 2 case presentations from Ethiopia and Zambia. So without further ado, I will be introducing our first speaker for the session, Dr. Marie Nyangasi, who is the head of the National Cancer Control Program at the Ministry of Health in Kenya. She's a medical doctor and a global health physician with over 30 years of experience spanning over in oncology, in clinical practice, to policy and governance. She has led the formulation of and implementation of various cancer policy documents, notably the Kenya's cancer policy, palliative care policy for 2021-2030. Also 2 national cancer control strategies and various cancer guidelines. She has also led the scale-up of breast and cervical cancer screening and early detection programs, as well as the establishment of regional cancer treatment centers and access to medicine initiatives. She is a committee member of various organizations, such as the UICC, Kesho, Aortic, and Women Lift Health Leadership Program 2023 alumni. Please help me welcome Dr. Nyangasi. Good morning, Dr. Nyangasi.
Thank you very much for that kind introduction.
Welcome. Thank you for being here. Yes.
And I want to thank you for giving me this opportunity to give a didactic presentation about capacity building of health workforce in cancer. So, as we know, the cancer burden is on the rise in the world, and of course, in the low and middle income countries is where we see the greatest burden of the disease. And Kenya has not been spared. We're also witnessing a shift in the epidemiological profile of cancer, with cancer now being the 2nd leading non-communicable disease. So what have we done? We have developed a number of key strategies and policies towards addressing the rising NCD burden, including cancer. And we are looking at a system strengthening approach where we seek to address all the pillars, the health system pillars in terms of improving access to care, service delivery, research, training, in the area of leadership and so forth. So the initiatives that we have done, especially in the cancer space, is around capacity building our health workforce to be able to better deliver cancer care. So when I talk about capacity building, I look at it in two ways, because we have the primary workforce as well as the specialized health workforce. So capacity building for cancer has to look at these two targeted groups because they both play complementary roles in ensuring that we deliver good service. So, so I will speak to the two, specifically what we've done around the primary health as well as the specialized workforce. So in the primary health workforce, what we observe is that a majority of our health workers are not well prepared to handle cancer screening, prevention screening, and early diagnosis, and even referral of patients. We used to say that the reason our patients are getting late-stage diagnosis is because they don't know about cancer, so they come late. But as research is coming out, we are seeing that the health workforce, actually the health system, is contributing greatly to late-stage diagnosis of cancer. And when again you interrogate once more, you find that the reason that is actually at the area of the index of suspicion of our health workers at the primary level, where we have observed patients being treated severally for communicable diseases before finally a suspicion of cancer is made and the appropriate tests are carried out. So you can see we have major gaps. And so as a country, what we've done is we've embarked to train primary health workers on early diagnosis of cancer. Specifically, we are looking at the main cancers, which is breast cancer and cervical cancer. But we have also what we've brought on board, what we call the e-learning. So what we did is we sat down with the experts in the cancer space across the continuum of care and developed content that is relevant to Kenya. So we looked at what are our problems, what are our key cancers, and then in our landscape, what are the appropriate ways of handling a patient or a client, and then what are the diagnostics we have in place, and so how can we guide our primary health worker in order to be able to refer. So we have customized e-learning materials, which we have put in our ministries, what we call the virtual academy, and they're actually the most active. As we speak, they are so active. We have experienced nearly 5,000 health workers onboarding. Of course, completion rates is another story because it varies. We see completion rates higher when you use the mobile application, the web-based platforms, but lower when you use the mobile application. So we have two versions, web-based and mobile. But nevertheless, it's a platform that has enabled our health workers to access some of these material free of charge at the convenience of the workplace without having to move from their places of work. So it's also efficient because we are providing it at the place of work, so we do not incur costs to transport a health worker to a site for training and to take trainers to that site as well. And we also are able to optimize service delivery. We don't interrupt because the health worker can read as they are continuing to provide their services. So those are the advantages. Now, so we have also Of course, there are things that we cannot do purely on e-learning, like when we are training workers on how to screen and treat for cervical cancer. So what we've adopted is what we call a hybrid approach of training of health workers. So initially we used to take health workers, these primary health workers, for 5-day, sometimes even longer trainings. But now what we do is that we encourage them to onboard the e-learning materials and learn the theory parts. And then we invite them for only short, like 2 or 3 day trainings, where now we concentrate on the skills. So this has helped us a lot because, again, we get people who are interested in learning and interested in providing the service, rather than before where we would get anybody and some are not really keen. And then number 2, they will already have interacted with the material. So by the time they're coming for the training, they are not green, I do not call green here, but they are not so unaware. It's like they're refreshing and just compacting knowledge on already something they've already read about. And so they are eager to see exactly how does this skill actually, how can we, so we call them the hybrid trainings, and that's what we are using currently. So we encourage people, and once we help workers to onboard, and once we achieve a class that is of 25 participants, then we go to that county and deploy the training. Again, what I want to say is that in Kenya, we have a devolved system of government. We have 47 counties. So the most efficient way of training our primary health workers is training what we call trainer of trainers. So we have resourced every county with the TOTs, trainer of trainers, so that they don't rely on the national government for subsequent trainings of the other health workers in the counties. They only need to be ready, and then we support the TOTs to go and train a class from the local, at the county level. So that has also been efficient. But we maintain the quality through mentorships and just providing regular technical assistance. Now, when I move to the specialized workforce, what we have done in this area, when we started in the cancer program in 2017, we only had about 11 oncologists in the country. And in a country where we have 42,000 cases every year and high mortality rates, this was a significant challenge. So we went around to sit with the universities and international bodies such as the IAEA, and they agreed to set up local training programs, because for us, we thought relying on sending people away for training, first of all, was so expensive. And then second of all, it was not sustainable because some of them were not keen to come back and there was a lot of brain drain. So we felt that the way to go was have local training programs. And so, of course, the challenge with that is that the quality at the start, getting enough faculty is a challenge. But we said if we never start, we will not grow. So we have to start somewhere. And that way we were able to set up a local radiation oncology training program. I'm proud to say that this year we'll be graduating our first cohort. And so we will have 10 new radiation oncologists graduating from this program. And so that way, next year we expect another 9, we have another 8, another 11 in the first year, and we are going to admit even more once, So we see that as a sustainable way to grow our numbers. Apart from that, we also have a local medical physics program at the Technical University of Kenya. We also have a local oncology nursing program and a radiation technology training program. Recently, we've started a pediatric oncology training program at Moi Teaching and Referral Hospital, and also a pediatric oncology nursing program. So this is how we are working to strengthen our local capacity for management of cancer. And we hope that in the next few years, we will not be talking of lack of specialized human resource, Rather, we will be talking of how we are now able to treat our patients better. Thank you so much.
Thank you so much, Dr. Nyangasi. That was a wonderful didactic presentation, and it was just wonderful to also hear about the Kenya experience. I truly appreciate the fact that you also spoke not only about the in-service work that you're doing in the country, but how you are increasing cancer care delivery, but specifically oncology capacity in Kenya. So that's wonderful. Also, just I'm not sure I mentioned that earlier, but if you have any questions, comment, please. We would love to see those in the chat. We will wait until we have all of our three presenters complete their presentations before going into our Q&A session. And I don't see anybody introducing themselves in the chat, so please do that. I want to encourage you all. So we'd love to see where everyone is from. So thank you again, Dr. Nyangasi. We'll move to our next presenter, who is Takalesh Moges from the Ministry of Health in Addis. So welcome, Takalesh. Quickly to introduce Takalesh, she's the cervical cancer focal person for the Ethiopian Federal Ministry of Health, and she has held this position since 2013. Takalesh is a reproductive and public health professional working in the Ethiopian health system as a cancer training organizer and national cancer control plan developer for the last 20 years. She has been involved in coordinating and developing different information, education, communication, and behavior change communication materials, cervical cancer training packages, and guidelines. She also has participated in local, regional, and international meetings, including the 2016 Pink Ribbon Red Steering Committee in Rockville, Maryland, and others in Switzerland, and others in other regional consultation meetings, specifically on the elimination of cervical cancer. Takalesh has also coordinated different meetings and workshops, specifically around cervical, breast, and prostate cancer in Africa. Takalesh, welcome, and we look forward to hearing you speak and present. Thank you. I don't know if, Takalesh, I don't know if you can hear us, or would you like for us to share your slides? Sure. Yeah, it doesn't seem like Takalesh is possibly having some internet issues. If that is the case, we can probably move on to memory, and perhaps Takalesh will have some.
Oh, sorry.
Oh, no problem. Okay.
Okay.
Welcome.
Can
Thank
I
you.
share my slide or?
Yes, please.
Okay, good afternoon, good morning, everyone. My name is Takalesh from Ministry of Health, Ethiopia. So I am going to present the experience of Ethiopia on cervical cancer program. Specifically, the title given for today, capacity building in cancer service delivery at the primary care level in Africa. So we will see experience of Ethiopia. So what it seems the health workforce, advocacy, and political or policy perspective. So my presentations focus on cervical cancer program, specifically on secondary prevention. So when my presentation contains background, how to implement approach and what we lesson learned from this implementation as a whole. So when we go to the background, this is for your information. This one is Ethiopian map.
My apologies, Takelish. I don't know if you are moving your slides because we're still on the first slide.
I'm moving.
Oh, okay, because it's not showing here.
Still
Unless
not
it's
showing?
No, it's just on the first slide.
Still, okay. Maybe I will stop and re-share it.
See if that works. If not, we can do it on our side.
What about now?
We can see your slides, but it's I'm not sure if you have moved it to, but okay, perfect. It's working now. And I don't know if you also want to go on the slideshow, but it's fine. Thank you.
Okay. So this is Ethiopian maps. So as you know, it is found the eastern part of Africa. So when we see the population of Ethiopia, it's around 120 million. So among these, the annual cancer cases more than 77,000. So in Ethiopia, when we see the health facilities, so we have more than 400, so close to 200,000 is health posts. So the other one is we have more than 400 hospitals. So when you see the health post, each health post or one health post serves for 5,000 population. So we have around 40,000 health extension workers. So those health extension workers works in the community. So the other one is the cancer. When we see the cancer days, it accounts 9% from all cases from non-communicable diseases. Among these cancers, cervical and breast cancer is a leading cause of cancer in Ethiopia. So specifically, when we see in number, cervical cancer is the leading cause of the second leading cause of cancer in Ethiopia. So it estimated 7,445 new cases annually. So among these, more than 60%, which is 5,338 deaths occur in each year. This is the sources Global Count 2020. So when we see the cause of this death is due to the patient came to the health facilities at late stage. So because of that, the survival rate is very low. That's why majority of the community have no information about the screening service, and also there is lack of prevention services in our country. That's why they go to the facility at late stage. It's more than 80%. So when we see the priority response in our country, there is a strategy document. So we have a guideline, we have a cancer control plan. So we have different protocol and also training material, especially on cancer. So we try to expand the service, especially screening and treatment service nationwide. So nowadays, we try to access for the community. And now more than 1,300 health centers or health facilities are providing the screening and treatment services. So which means in each district, one health facilities are providing this screening and treatment services. So when we see the capacity building, there is health care worker. So more than 2,000 healthcare provider trained with cervical cancer program, which is screening and treatment services. So the other one is we have a tool, monitoring and evaluation tool, just to capture the data from each facilities. So we are generating evidence on this program. So the other one is what our priority response is the quality assurance mechanism. So we already developed a mentorship guideline integrated with breast cancer. So we tried to provide quality of service for the patients. So the other priority we response on this program is we have a network, local experience sharing platforms like Zoom meeting, and also experience sharing from one region to another region. So there is a networking on these experience sharing platforms like review meeting. So when we see the implementation approach, there is a 3 level. There is some, we do some work at national level. So at national level, we developed guidelines, training materials. So we provide supplies for facilities, and we conduct TOT training, trainers. So we do supportive supervision just to improve the quality of service, and also we do continuous quality improvement through mentorship and supportive supervision. So we have a technical working group at national level, which engage the partners in the other local and associational profession. So when we go to down, there is regional states. So we have 13 regional state government. So all this regional state government has own regional health bureau. So this regional health bureau will cascade the basic training for their facilities, and also they monitor the implementation, and they will do supportive supervision, and also they provide logistic for the facilities. And in addition to this, they deploy staff for their facilities, and they have own retention mechanism for the staff. The other one is they have monitoring and evaluation system, which is DHI system. So we are capturing the data through DHIs. So when we go to the facility, they have their own responsibilities. So among these responsibilities, they have to provide service for their clients. They have to create demand for the community. And the other one is they have to report what they do in the facilities. The other one is service quality improvement. So they have a mechanism to control the quality improvement. So this is what we have done or what we are doing in during the implementation. So the other one is what we learned from or during the implementation of the cervical cancer program in Ethiopia. So with a committed capacity building at primary healthcare level, cervical cancer screening and treatment is scalable approaches. So we can easily scale up the program if there is commitment at all levels. Today in Ethiopia, as I said, has over 1,300 public health facilities providing cervical cancer screening and treatment by using see and treat approaches. Still now we are using VI screening for general population, and also HPV DNA test for women living with HIV. So our treatment modalities for DC and treat approaches, cryotherapy and thermal ablation, and also among 1,300 public facilities, around 50 hospitals are providing LEAP services. So the other one is there is high-level policy commitment. It's crucial to implement the scale-up cervical cancer program. So still there is a good commitment from the government side by allocating the budget to procure cryotherapy and the LEAP machine. So as I said, the government is committed. So we procured 1,500 cryo machine, more than 50 LEAP machine procured 3 years ago. So that is indicates the government commitment. And also we have a costed national cancer control plan in the ministry. So the other one is we have monitorable indicator for cervical cancer and other cancer designed to the national DHIs. Already included 4 indicators in the DHIs or HMIs. So we are capturing the data, or the data will be entered every month. How many women get screening service and how many lesions and so on. So it is our program is monitorable. The other one is a networking and a linkage of high qualified professional with mid-level professional at referral center. It's important. So this is would smooth skill transfer and the quality assurance. And also the system is already established, like transferring knowledge. So this is all about my presentation. If you have any question, so it's welcome. Thank you.
Wonderful. Thank you so much, Shakalesh, for this great presentation. We truly appreciate it. And again, if anyone has questions they want to put in a comment or waiting, so we have one more presentation. I think I see one here, and we'll address that as soon as we hear from Memory. Hello, Memory. I wanted to quickly introduce our next and last speaker for today's session. So Memory Chitambo Sabonko is the current program manager for cancer at the Clinton Health Access Initiative, CHI Zambia office. Her current portfolio entails playing a cross-cutting role in the UNITAID-funded cervical cancer program management by interfacing directly with internal and external stakeholders and coordinating execution of the country work plan under the auspices of the Ministry of Health. CHI's driving role on the cervical cancer program has been focused on secondary prevention of cervical cancer, which centers on the women across the continuum of care, from screening to treatment and follow-up. So before this current role, she worked on various HIV prevention, treatment, and research portfolios within CHI, but also other organizations. And she will endeavor to support global efforts towards cervical cancer elimination and the prevention and control of other cancers. Good afternoon, Memory. Thank you for joining us, and we look forward to hearing your presentation.
Thank you, Hawa. Good afternoon, everyone. Let me just share my screen. Yeah, thank you so much. And thank you for the opportunity to be able to share lessons which we've learned in supporting the Ministry of Health in Zambia in the cervical cancer elimination efforts. So I'll start my presentation by first giving an overview of the epidemiological data on cervical cancer in Zambia, as well as the approach that government and ourselves as partners are taking towards achieving the cervical cancer elimination initiative. And so Zambia has a population of approximately 19.6 million people. And in terms of cervical cancer incidence, we are third at global level with an incidence rate of about 65.5 per 100,000, and cervical cancer mortality rate of about 43.4 per 100,000 women. And so in terms of approach and strategy in trying to reach the targets of cervical cancer elimination, we've adopted the WHO cervical cancer elimination strategy, but also implementing under the auspices of the National Cancer Control Strategic Plan. And so the current strategy that we are using is running from 2022 to 2026. And we are hoping that across the 3 pillars, HPV vaccination by 2026, we should be able to reach 80% of our girls, and then also 60% screening target for women aged 25 to 59 years, and 90% treatment, both pre-cancer and invasive cancer treatment. And so in terms of HPV vaccination, as a country, we are giving the vaccines to girls aged between 9 to 14 years. And this is delivered under the biannual immunization campaign. So we haven't yet incorporated this through the routine immunization strategy. So this is done biannually. We are also conducting cervical cancer screening, and we are using visual inspection under acetic acid as well as HPV testing. And predominantly, we still remain a VIA-based screening modality, because this is the modality that we started with way back in 2006 and continue to scale up. However, since 2019, we've been trying to roll out and scale up HPV testing. The target population that we target for cervical cancer screening services is 25 to 59 years for HPV testing and 25 to 49 years for VIA. Our program for the cervical cancer prevention is predominantly led by the nurses. And we'll find out in the presentation on why this approach has been effective in our setting. And so far, we have 310 cervical cancer screening sites that are dotted across the country. In terms of treatment, so pre-cancer treatment is offered in primary healthcare level, and we use thermoablation as well as LEAP. While for invasive cancer treatment, we have one cancer treatment center that is based in Lusaka, the Cancer Diseases Hospital. So as CHAI, our program was built on supporting the Ministry of Health to build robust health systems in country and provide for equitable cervical cancer screening and treatment services to women across the continuum of care. And with the United Fund, we've been able to support cervical cancer screening by supporting the procurement of HPV testing reagents, as well as supporting VIA screening. And through this program, we've been able to reach about 29,000 women screened. We've also been able to support the Ministry of Health with the procurement and deployment of battery-operated portable thermoablation devices, as well as LEAP devices. We've also been able to prove delivery models where we are able to work with civil society organizations and affected women in the generation of demand and linkage to cervical cancer screening services. And here I wanted to highlight that in terms of pre-cancer treatment, we seem to be doing better with thermoablation device treatment, because mostly this one is done under a screen and treat approach, where the nurses that screen are able to treat, and we'll see the details as we go on. So we've also been able to support and scale up a robust patient management and tracking systems to make sure that the women that are actually being found with advanced lesions are able to attend the referral site. Sorry, my screen seemed to have, frozen. Yeah, so this is just to illustrate our human resource base that we have and what we've been able to, support. So the foundation of the Zambian health workforce is actually at community level. And the cervical cancer program has leveraged the existing health workforce structure to provide the services. So when it comes to demand generation, as we are able to see on the slide, the community-based health workforce form the foundation of this. And we've been able to work through the safe motherhood volunteers, the neighborhood health committees, the HIV treatment supporters, to be able to demand, to create demand for the cervical cancer prevention services. And all these cadres feed into the formal health system through the existing health facility and district staff, because they are all the activities at community level are being overseen by the district health promotion officers. And so when it comes now to the screening services, at the time that the program was launched in 2006, an evaluation had to be done on what would sustain the program. Mainly, we've seen that the programs that are offered by higher level cadres, such as the doctors, don't seem to be sustained at primary healthcare levels. Because when our doctors graduate, they are only available at primary healthcare level, maybe for the first 1 or 2 years of their graduation. From there, they go into specialty training. And so we, as a program, we had to take the approach to look at the most available cadre at the lowest primary healthcare level, and these were the nurses. So as at now, the nurses form the base and the foundation of the screening program, and they provide both HPV screening and VIA, as well as pre-cancer treatment. So for the pre-cancer treatment, they are only able to offer thermal ablation or cryotherapy. Then for the LEAP treatment services for women that do not qualify for thermal ablation and need LEAP services, these are then treated by the clinical officers, the medical licensed, and the doctors. And on this, I want to mention that clinical officers and medical licensures were only integrated into the program in 2021. And this was after we had the same challenge that I mentioned on the doctors, where we have these doctors, you train them and they are back for specialty training and a gap is left. So the country had to make an evaluation of which other cadres have surgical skills and can manage the complication of LEAP services. And this is how we have clinical officers and medical licensures coming in. For the sake of people that may not understand who a clinical officer is and a medical licensure, so clinical officers are like medical assistants, maybe in other countries, whilst medical licensures are mainly the clinical officers that have gone into deeper training to be able to handle other more advanced surgical skills, such as doing a cesarean, doing a lipoma. So they go a step further. And then after the LEAP treatment, and if a woman requires further care, they are then referred for biopsy and histopathology. And this is just to mention that the biopsy is actually offered by the same cadres that offer LEAP services. And then at a higher level, we have the oncologists that offer invasive cancer treatments. So this defines the cascade of cervical cancer management for women that we are seeing within the Zambian health system. Sorry, my screen has frozen again. Okay, there we go. So the overarching factors to support the capacity building for the program service delivery at primary healthcare level have been premised on a decentralized principle. I think this I had mentioned even on the previous slide. And I'll begin from my right. So from program leadership and management and governance, our program has premised on allowing the provincial team to manage and coordinate cervical cancer services. So we have the cervical cancer provincial program coordinators. Most of them are gynecologists, but where there is no gynecologist, we still have other doctors overseeing this program, and these are assisted by the district nursing officers at district level. And then at facility level, we have the facility coordinators. We also have the same district and provincial health staff actually managing the trainings and mentorship. And just like Kenya is doing it, we were able to see that once we have the trainer of trainers based at sub-national level, there is a lot of sustainability in the selection of cadres to be trained, but as well as having program management sustained at that level. And also the financing mechanism, be it the ones coming from Global Fund, government to government, or the national health budget, the trainings, mentorships, and coordination funds are handled at provincial as well as district level to enhance program coordination. And also we have partners within the province supporting intra-provincial partner coordination meetings. And so this feeds into a sustainable health workforce, where now we have from facility, we have this community health workforce that is at the front line and the backbone of the services that are being offered. And also we've seen that once we use the community themselves, we use the nurses that are, you know, at the base of the front line of the health services, these are less affected by attrition. We've seen very few movements, and even when they move, they'll still move to another primary health care facility where continuity of service is maintained. And the cervical cancer program is also integrated into other health programs. And from the time that this program was built in Zambia, we see it being built on the HIV program, the MNCH services, and all other existing primary healthcare level programs. And so even when the staff go for, you know, outreach services, cervical cancer is incorporated within these same services. And we've seen that this actually is a factor that has supported sustainability. We also see a lot of program localization and ownership. And last but not the least, this is just to share the key enablers. I think some of them have said for the success of the program, and the pillars that we've seen that have supported the program at national level, actually the existing political will and coordination between government and ourselves as partners, and also the health workforce and the training and the mentorship delivery tools that I had said that are decentralized level, as well as health financing mechanism, where we've seen a lot of resource synerging, mapping, and, you know, sharing lessons at partners to avoid duplication of efforts. This is where I am. Thank you so much. This is a picture of a woman that had undergone cervical cancer screening at Chilonga, one of the CHI-supported screening sites in the northern region, and it's a quite hard to reach area. So thank you for the presentation.
Thank you so much, Memory, for a great presentation, very rich, and really happy to see about the great Zambia experience, specifically for cervical cancer elimination. And also wanted to highlight that I really appreciate the fact that you have this kind of incremental target with the 80, 60, 90% to make it a little bit more realistic, you know, in this for the Zambia context. So I appreciate that very much. So this kind of concludes the presentations section for our session today. So I want to thank again all of our presenters for the great presentations. And now we're moving on to the Q&A. And we basically have about 30 minutes. So for the next 30 minutes, please feel free to either input questions in the chat or unmute yourselves. I see here that Ricky Liu has asked a question to Takalish regarding the 4 cervical cancer indicators in the HMIS. And Takalish responded saying that the indicators are screening rate, positivity rate, treatment rate, and follow-up rate. One other question that Ricky had for Takalish was around the screening technologies that the clinicians are being trained on. Takalish, I'm not sure if you're still online and want to respond to that. And then we'll move on to other questions. If not, sorry. Yes, it would be great if your bandwidth permits, if you could have your, if you can turn a video on, Dr. Nyangasi and Takalesh, please, if possible. No worries. So Takalesh, I see that you muted yourself, but I'm not sure if, okay. Hello, Takalesh. Hi. I think a question from Ricky was around the screening technologies that the,
Okay.
yes,
Okay.
for training, yeah.
Thank you for questions. So in our country, our screening modality is via visual inspection with a stick acid for the general patient. When we go to the woman living with HIV, at some facilities, we are providing HPV DNA test. So still nowadays, our screening uptake is around 1.2 million women getting these services. So the other one is already mentioned. Our treatment modality is LEAP, thermal ablation, and also cryoation for the pre-cancer lesion. So if it is invasive cancer, we will refer to the referral hospitals. So we do have 4 radiotherapy centers in our country. So all these hospitals are providing comprehensive cancer care, including chemotherapy, radiotherapy, surgery, and so on. So our plan is to expand more up to 7 hospitals. You know, our population is more than 100 million, so it is difficult to address all this population. But we have some progress. 1 year ago, we have only 1 radiotherapy center. Nowadays, 4 radiotherapy centers in our country at different regional states. So I think the answer is, the question is responded, yes or no?
Yes.
Okay.
Thank you, Takalesh. Thank you very much. Ricky has also one question specifically for memory. And the question is, for the HPV-based screening, I'm curious about self-collection and how it figures into expanding access and perhaps mitigating the workload burden of nurses to screen women.
Yeah, thanks, Ricky, and thanks, Hawa. So I had mentioned that we started implementing HPV testing in 2020, so we are quite young. And as a nation, our guidelines actually advocate for HPV self-sampling. And so we are still learning the lessons, we are still documenting, but the whole idea of recommending HPV self-sampling is to reduce the workload and also be able to roll out the service to community structures so that women can feel free to self-collect even at community level. And these are the lessons I think that came in during COVID, where access to facilities was limited. So we are documenting lessons, but as at now, I can say more than 90% of HPV testing is done through self-collection, because most of the kits that are bought by government and partners are self-collecting kits. So we'll share lessons as the program goes on.
Great, thank you very much, Memory. And thank you, for Ricky, for the questions. Anyone wanted to unmute themselves for a specific question? Okay, well, I have one. Those were really terrific presentations. And you had touched on that, Memory, during yours for the Zambian context. And I was wondering, in terms of sustainability, what are some factors that possibly threaten that sustainability? And that's for all contexts of Zambia, Ethiopia, and Kenya. But what are some of the factors that could potentially threaten that sustainability? I mean, you touched on health financing, but are there any other factors that you could potentially see threatening the sustainability of your strategies in your specific context?
Maybe, can I say something?
Sure.
So in our country, I think it is there is no problem for the sustainability already we established in the system. So I think without any problem, the program will sustain, because without any support by government commitment, we establish all these activities or programs in the health systems. So without any problem, it will sustain for us, because there is no partner support on this program. Our partner support is only from the HIV women living with HIV through CDC support, unless otherwise the whole cost is covered by the government. So no problem for the sustainability. Thank you.
Thank you, Dr. Lish. I see Dr. Nyangasi had her hand up.
Yeah, okay, thank you. Okay. From me, where I sit, I think we also have good government. Political goodwill is good in Kenya, especially around. In fact, the current government agenda is a bottom-up economic transformation agenda, keen on prevention. But we see threats, especially with the economic recession. I think the global recession has challenged our supply chain, because the value of the currencies keep shifting. So you find like when you secure some, let's say, supplies, there are challenges with accessing, I don't know, dollars and so forth. So I think the threat is there are always things that are beyond us, such as the global economic recession. We also need to be wary about issues that might threaten supplies, especially for HPV reagents and commodities, because as we are scaling up, we are very much reliant on the global market. We don't have a national production. So we don't have a local production for vaccines, neither are we locally producing the HPV reagents. So we are prone, I think the threat is, suppose there was, because of climate change, there was some problem at the factories where they're produced. So we see that as a threat. This imagine issues like climate change, global pandemics, COVID time, it was difficult to get some supplies in the country. In fact, our screening program declined, as well as vaccination. So those are the threats I see. And maybe these are things that we can mitigate by having, let's say, encouraging, because we have a burden of this disease in sub-Saharan Africa. So why not encourage maybe a regional manufacturing or regional procurements, so that we can ring fence our health products and technologies, so that we can have our services for screening going on uninterrupted in the future. Thank you.
Great. Thank you, Dr. Nyangasi.
Yeah, thank you. I think much of what Kenya and Ethiopia have shared are similar to Zambia. And I had mentioned the issue of health financing, because it's the pillar of everything that we are looking at, be it HPV vaccines. So the Zambia program in terms of HPV vaccination, HPV testing procurement, most of it, I can say more than 60% of the budget is donor driven. And so this is where the risk comes in. But also the risk base for the prevention side is quite low. I would say low to medium. We have the highest risk as we cascade the woman towards the tertiary care. You know, as you saw, the health workforce at that level begin to decline, and the support for pathology services, oncology services is quite low. So the question that has been asked is the prevention side is producing a lot of women that are being found with invasive lesion, but you know, when you go up the cascade, the help that is coming from there is not very high. So it all centers around health financing on our end. Yeah.
No, I absolutely understand. Thank you so much, both of you, for all three of you for your responses. It is, and I also appreciate that Dr. Nyangasi did mention other kind of to see how we're all connected within the health system, you know, other issues such as climate change and obviously the pandemic, et cetera. I see here a few questions. There's one from Emily Kobayashi, who mentioned that, and this one is specific to Kenya, for Dr. Nyangasi. Could you share more about how the government is planning on hiring these specialists as they graduate from the program? So those are the oncologist specialists that you had mentioned in your presentation. How are they going to be integrated into the health workforce?
Okay, thank you for that question, Emily. So I want to just reiterate that we have what I call a strategic plan. In fact, we have just finalized our third one, which we are planning for launch. So these are the documents that the government uses to plan. So for example, the current strategic plan is outlining our human resource requirements for the next 5 years. And so usually what we do, we present this in our economic forums. And so they are able to make sure that they budget for employment of this workforce. Usually what I also want to mention is that I mentioned we have 2 levels of government. So we have the national and we have the county government. So if a health worker is to be employed by the national government, that budget will be catered for by the national, and these are the national referral hospitals. But for the counties, they are also free to hire their health workforce. Our role in hiring and guiding is in guiding the counties to know what workforce they need to hire for a specific type of service delivery, so that we make sure we have adequate workforce for the service we want to provide. So we give them advisory and we follow up to ensure that they are able to implement what we have provided. So I think that is the way that we have put in place structures to make sure we have it in our planning, and also sensitizing the counties on their roles. Thank you.
Right. Thank you very much, Dr. Nyangasi. There's one other question from Julia Gage, and it is, could you please describe the data system you are using? You mentioned that the web-based system worked better than the app, and that was for the e-learning modules. I am interested in hearing a bit more about it.
Okay, thank you. It's not really a data system. I wouldn't call it a data system. It's a platform for learning. So, you know, like the way you have Echo platform and so forth. So this was just what you call the web-based platforms that we are using, which exist at the Ministry of Health Virtual Academy. Maybe you can just type it out and you will find out exactly what I'm talking about. If you just type Ministry of Health Virtual Academy Kenya, you will see the cancer courses and you'll be able to interact with them even from wherever you are. In terms of maybe the data systems we use, we actually just use the district health information systems for our cancer data. And we are able to actually follow our screening rates, our treatment rates, using the data the facilities report every month through the Kenya Health Information System. So even the treatment rates at our cancer centers, currently we have 6 comprehensive public cancer centers. We're able to get that information on the Kenya Health Information System. Thank you.
Great. Thank you very much, Dr. Nyangasi. And thank you, Julia and Emily, for the questions. I wanted to go back quickly to the e-learning platforms, and we've seen how they're being used in, and also how they are effective. So more from a web-based, the web-based platform than the mobile app. And I was wondering if that's also a strategy that either is being implemented in the country, or there are talks around implementing e-learning modules at some point as part of the health workforce capacity building strategy in Ethiopia and in Zambia. Either, I don't know if Memory or Takalish wanted to. Memory, do you want to? Yeah, thank you.
Sorry, I missed the question, I think, sorry.
No worries, no worries. So my question was going back to the e-learning modules, or any type of similar virtual, capacity building or training strategy. Is it something that is currently existing in Zambia, or are there discussions about it?
Yeah, so we're just testing our e-learning module that was supported under the PEPFAR Hub program. So we were developing, and then currently I think we are just receiving feedback from the people that have tested it. So we are almost there in doing virtual cervical cancer screening and deep services, but not as far as oncology and training.
Right. Okay, great, thank you. I don't know if Takalesh wanted to speak on the Ethiopia experience. Perhaps not. And apologies if there were some mix-up about the time, but as I mentioned earlier, the recording will be available in the next couple of weeks. Okay. I don't see any other questions in the chat, but one question I have is, and you had mentioned that memory was you are all training, those nurses, or we have oncologists as well, and how are they followed after training to ensure effectiveness of those training programs, but also how are we ensuring or preventing rather brain drain? And that's for all settings, again, all countries.
Yeah, so I think like I had mentioned, the training structure is more consolidated at provincial and district level. So we have the provincial technical leads and the district technical leads offering mentorship after the training. And so the structure is such that, so the training is normally a 10-day training, and then practice is started with a mentor that is with the provider for the next 1 month. And so this has to be a trainer within the district, because then it would be expensive to get someone from the province to go and sit with the trainee. So after the 1 month mentorship with the trainee, then the trainee remains alone. And at the 6th month, they then undergo a competence test for certification. So there is a continuous mentorship process that is going on. So in terms of brain drain, the nurses are quite a stable base. For most of them, even when they decide to go back for specialization, they'll still remain within the provincial structure, where maybe they want to do midwifery, they want to do theater nursing. They are better than doctors who migrate to the central level and the country capital. So, and even when we have movements, most of them, if a nurse moves from one district to another, they'll then continue providing services in other district, in the other district. So it equalizes and cancels out at that level.
Great, great. Thank you very much, Memory. Dr. Nyangasi or Takalesh, I don't know if you have any additional comments.
Okay. Thank you.
Thank you.
So regarding the training in our country, so the ministry will give a TOT training for the regional states bureau. Then they will give the cascading training for their healthcare providers, which are doing in the facilities. So we already established hub at regional level. So this regional hub will give a basic training for the health worker. So in our country, it is smoothly will give the training. Even the equity is very important during the expansion. So in our country, there is no problem because we have already established hub all over the nation. So regarding the oncologist, so the hospitals will recure.
Okay, so maybe if I can comment, my last comments, I just want to mention that also another strategy.
Sorry, there was a issue here. Takalish?
So, okay, can I
Okay,
continue?
sorry. Yes, I'm sorry. I think there was a
Okay,
interruption.
so
Yes.
regarding the clinical oncologists, the hospitals will recure the general practitioner, then they will send to the university, then they will take 3 years course for the clinical oncologist, then will go to back their hospital to give the service based on their agreements. So that's all about the clinical oncologists, how we give the training for them. Unless otherwise, the other one is just we give the training at regional level and also at national level, including mentorship training. So thank you.
Thank you, Takalish. Dr. Nyangasi, I'm not sure if you have any comments.
Apologies, I think I'm having a challenge with my internet. I was not even hearing. Anyway, so I wanted to mention that another approach that we are taking is to train, to approach the training institutions where our primary health workers are being trained. So, for example, we have the Kenya Medical Training College, where majority of our nurses and the clinical officers are being trained. Actually, 80% of our health workforce at the primary level are trained at the KMTC. So we have trained about a number of lecturers across the campuses so that they can be able to adapt their curriculum to include cervical cancer and breast cancer screening as part of their training for the students. The purpose, and as we train the lecturers, we've also equipped their skills lab through support from Clinton Health Access Initiative. I need to appreciate them because they gave us thermoablation devices and supported quite a number of these trainings. And we're able to just sensitize the health workers and equip. So basically the purpose is that even before the health worker is coming out, to join the workforce, they have an idea about what screening for cervical cancer treatment, precancerous lesion treatment is all about, and they are confident to use these, skills when they go out there, so that we are not waiting, we are closing the tap before, they come out. So that's a strategy we think will be effective in the long run, so that the health worker sees cervical cancer screening and prevention as part of their scope of work and not something that they'll need to be trained on to be able to perform. Thank you.
Right. Thank you. Thank you all of you for your responses. I don't know if anyone wanted to unmute themselves, giving the opportunity. Okay, I have another question. This is so interesting to me, so I'm excited. And all your responses are great. Your presentations were wonderful, so thank you for that. But I wanted to just touch on the fact that cancer guidelines in general, cancer prevention guidelines are ever evolving, right? So there are always those changes that make it challenging for providers to remain up to date with those constant changes. What are some approaches that you have used or that can be integrated as part of the overall capacity building strategy to address these routine changes, whether pre-service or in-service? Do you want to start in memory? Great.
Yeah, I can go first. Yeah, so for us, I think guidelines are developed in conjunction with the provincial technical leads. So whatever changes that are being made at policy document and program training level, the provincial technical leads are involved and they form quite a bigger input into those materials. And so as they go back for mentorship and service support, technical support, they then incorporate the various changes that have been made. And in the event where there's been some finalization and documentation, they are then able to share with the district supervisors as well as the direct interaction that they'll have with the facilities.
Great, thank you. Dr. Nyangasi or Takalesh, I'm not sure if you wanted to speak on your experience.
Okay, thank you.
Mhm.
Thank you.
Yeah. Sure.
So maybe regarding the guideline or any strategy, the ministry, as I said, the ministry will develop guideline and also different strategies. So after we develop these documents, the ministry will launch or disseminate these documents for all responsible bodies. Then after that, the facility or the institution will implement these documents as per the developed. So based on that, we are implementing or doing such like this. Maybe in pre-service, the oncology is already included. As I said, clinical oncology already doing as pre-service. So the higher university, like Addis Ababa University, also working on this program. And the other one is like radiotherapists, also training will be given through the health system or universities. I think the other one is short-term training, like 10 days or 1 month training will be given through the training center or continuous professional institution will give all this training, unless otherwise the pre-service is conducted by the university, or in the in-service training is will be given in training center. This is what we have doing in the ministry. The other one is all developed training material, strategy, and the guideline will launch for all responsible bodies to implement that documents. I think this is what we are doing in the ministry.
Great, thank you, Takalesh. Dr. Nyangasi, I'm not sure if you wanted to chime in. If not, it's okay. We can, I see here, Julia also had another question, which is related to a question that we had as well, is around the type of civil society partnerships that have been explored in program planning. Are you engaging with civil society or even any other patient groups to help build your efforts in country?
Yeah, sure. And I think I had on one of my slides, I had projected that fact that I think from not just the child program engagement, but as well as at national level, the civil society organizations are part of the groups that are making decisions. In the technical working group, we cannot form a core if there is no civil society that is present, be it from the prevention side all the way to the treatment side. So on the prevention side, we have civil society organizations that are working using social media campaigns. We have the ones that, are working through the media. We have the civil society such as the Zambian Cancer Society that are helping in providing direct service delivery. On the prevention side, mainly we have Teal Sisters and Karen. You could have seen on Facebook that she's doing a lot of work on that. And so we have them at whatever policy forum that we have to form, from the technical working group to the development of guidelines, to the development of IEC materials. And without their validation, I think nothing can go through. And when we move to sub-national level, we have structures that, are able to represent patient survivors, women that have undergone screening, and also generally working with the community gatekeepers, the traditional leadership system, the community health radio stations that are there. So I think that recognition has been there from program inception, and we can't move forward where there is no endorsement of representing the consumer of the services that we are offering. So we have quite a strong base for civil society engagement. I'm sure you could have heard from OD, Karen, the Childhood Kayola Foundation, all these. I think they've been attending some of these meetings that we are all there. Yeah.
Great. Thank you very much, Memory. Dr. Nyangasi or Takalish. Absolutely, Julia. Yeah. So it's very exciting to hear about the power of collaborations. Takalish, I see you're muted yourself.
So could you repeat the question, maybe?
The question, yeah, sure. So around the type of civil society partnerships that you have used to help build your efforts.
Okay. So as I said earlier, we have a technical working group in the ministry. So in this technical working group, there is a different member included in this TWG. One of the member is different professional association and civil societies representative, and also partners and universities also part of the technical working group. So based on this, we are doing different activities with this team, because they have different experience, and also they have different knowledge to work with them. So if we want to develop guideline or different training material, we will use this TWG for the purpose of these materials. So in our country, we use this experience. Maybe to share the community experience, we do have health extension worker, as I said, more than 40,000 health extension worker in our country. So all this health extension worker in workers in the community, just to create awareness about the screening service, about the risk factor, and all about the prevention, and also about the screening service importance. So they will create awareness, then will link to the facilities for the screening services. So this is already established system in our country. So I think this is a good opportunity for us, especially for the prevention service in the screening service in our country.
Great, thank you. Thank you very much, Takalish. I'm not sure if Dr. Nyangasi has a comment, and I'm also being mindful of time here. I see that we are right at 10:30, so I could go on and on about this topic. So I think it's time to close our Q&A session. I wanted to thank our panelists for wonderful presentations and wonderful responses. This is extremely exciting to see what's happening on the continent and how there's so many similarities, but also we can learn a lot from one another. So I'm grateful to the Africa ECHO team for highlighting those different country experiences and how we can learn from one another. I want to turn it over to Charles or Mishka to close out. Thank you.
Thank you very much, Hala, for your fantastic leadership today. And thank you to Mary Takalesh and Dr. Memory Takalesh and Mary for your presentations and the discussion. We will be reconvening on July 18th for the next session. It will be focusing actually appropriately on health financing. And in addition, we will be circulating after this meeting our annual Africa ECHO evaluation survey. It's a Google link. We invite all to share their inputs. This is how we design the curriculum and the format and the also the steering committee for each year. We function from September to August of the year. So this month we launched the survey, and then we will share back the survey results in July and then convene the steering committee starting in August to prepare for the next year of the Africa ECHO. So look out for that via email from our Kenco hub for this Africa ECHO. And thank you very much for joining everybody today. Take good care.
Thank you, everyone. Have a great day.
Thank you, everyone.
Thank you. Thank you. Bye-bye.